A great pleasure being here. I was asked to discuss the treatment of advanced soft tissue sarcoma with a special focus on targeted agent treatment and the impact of some of the newer drugs. The background is that in advanced soft tissue sarcoma we have only a limited spectrum of active drugs. We have the three classical active agents, which are the anthracyclines, ifosfamide, and DTIC. We have just two more recent agents that have been registered for sarcoma treatment. Several years ago, trabectedin, and just recently, pazopanib. A few other drugs are commonly used in advanced soft tissue sarcoma, but nevertheless are unregistered in these indications, and they include gemcitabine, docetaxel, trofosfamide, mainly in Germany and Austria, and also temozolomide. The ESMO guidelines state that for first-line treatment, standard chemotherapy is based on anthracyclines as first-line therapy. There is still no formal demonstration that a multi-agent chemotherapy is superior to single-agent chemotherapy with doxorubicin alone, at least in terms of overall survival. However, we have very convincing data that the response rate and also the progression-free survival are statistically significantly superior to single-agent therapy. And following this, multi-agent chemotherapy with anthracyclines plus ifosfamide are considered the treatment of choice when the tumor response is felt to be able to give an advantage and the patient's performance status is good. So combination therapy should always be used in the neoadjuvant setting, in the multimodality treatment, and also in patients with a symptomatic disease where a higher response rate and a longer progression-free survival are considered to be of advantage. Few more studies have been done in the refractory disease situation after failing anthracyclines and or ifosfamide. An American study has tested the combination of gemcitabine plus docetaxel compared to gemcitabine alone, and it has been shown that the combination is superior in terms of progression-free and also overall survival shown here. However, this only applies to patients in a better general condition. For patients with a bad performance status shown over here, there is no clear advantage for the combination therapy. So again, combination should be used only in patients with sufficient general condition. Another study comparing gemcitabine now in combination with DTIC compared to DTIC alone has been conducted by the Spanish sarcoma group, and also a significant improvement was shown for the combination with respect to progression-free and also overall survival shown here. Trabectedin has been studied in a number of phase 2 trials as a single agent in patients having failed doxorubicin and ifosfamide, either given in combination or sequentially, or to those patients who were not able to tolerate one of these drugs. Trabectedin is a drug that rarely results in a real RECIST-based response. So the the partial response rate shown here is quite small. Overall, over these three studies, it's approximately 7-8%. However, the benefit of this treatment is the high clinical benefit rate, averaging about 50%. And the majority of these patients have a stable disease, which is quite long, meaningful, stable disease for more than 6 months. So the overall benefit is quite good. However, the shrinking, the response rate is quite small. Nevertheless, it has been shown by a number of studies that for many patients with advanced soft tissue sarcoma, tumor shrinkage, RECIST-based response is not the most important issue. It seems to be more important to offer the patients a long-term disease stabilization at a lower toxicity cost. The pivotal trial for trabectedin was a comparison of trabectedin in the classical schedule for soft tissue sarcoma, which is a 24-hour infusion every 3 weeks, compared to a 3-hour infusion once a week. And there was a statistically significant benefit for the 3-weekly 24-hour infusion, and this study led to the registration of trabectedin in many countries around the world. Trabectedin works independent of age. Given the good tolerability of this drug, it can be used in younger and also in older patients with a comparable benefit. There is no real difference between the two age groups below and above 60 years. Finally, pazopanib is the most recent addition to the armamentarium of drugs in refractory soft tissue sarcoma. Pazopanib was studied in a double-blind, a placebo-controlled randomized phase 3 study showing approximately 3 months benefit in progression-free survival. However, even without crossover, there was no significant benefit for overall survival. It has already been mentioned in the previous talk on adjuvant therapy on the background of soft tissue sarcoma that one of the most important things is that soft tissue sarcoma is not one disease, but is a big, huge bag of different diseases. This is showing the taxonomy of soft tissue sarcomas. We are counting more than 50 different subtypes of soft tissue sarcoma, and it has been shown that they behave quite differently. They respond very differently to different chemotherapy agents. Some drugs are very active in one subgroup, are completely inactive in other subgroups, and therefore it has become increasingly important to study soft tissue sarcoma subtypes as a specific type of disease and not continuing to study this disease as a mixed bag of 50 and more different subtypes. By the way, from my interpretation, this is one of the main explanations why adjuvant chemotherapy has not yet been proven beneficial for soft tissue sarcoma as a whole group. The combination chemotherapy used in the studies, as was discussed in the previous talk, may work in some subtypes but work less well in other subtypes, so it's not really very difficult to explain why it doesn't work so nicely for the overall group. For the next part of my presentation, I will focus on a few of these molecularly defined subgroups, and we should keep in mind that the real background for doing this has been the detection of gastrointestinal stromal tumors as a distinct entity within the big group of soft tissue sarcoma. The development of imatinib as a molecular targeted therapy for GIST therapy was actually the starting point of looking into sarcoma therapy in a more specific way. You know that chemotherapy never worked in GIST, but imatinib has completely changed the treatment of this disease, and starting from this point, we have developed also some newer treatments for other specific subtypes within the group of soft tissue sarcoma. A brief overview on some subtype-specific treatments. I already mentioned that combination chemotherapy should be considered in patients with a curative intent. That will be the big localized tumors where we try to downsize the tumor to allow surgery after a successful pre-treatment. If we consider adjuvant chemotherapy, this should always be a combination. If we cannot give combination, we should leave it at all. And also patients with a limited metastatic burden should be considered for more intense chemotherapy, and then maybe look for a surgical approach to resect residual metastatic disease. Ifosfamide is especially active in synovial sarcoma. Trofosfamide, an oral drug, can be nicely used in elderly or otherwise unfit patients who cannot tolerate aggressive single-agent or combination chemotherapy. Taxanes are a very nice example. There have been a couple of studies for taxanes in the big bag of soft tissue sarcoma, the overall result was completely negative. However, there was one study in which angiosarcomas were overrepresented, so the overall study was negative, but the subgroup of angiosarcomas responded quite nicely to treatment with paclitaxel in this clinical study. So this led to the recognition that taxanes are completely inactive in the overall group of soft tissue sarcoma, with the exception of angiosarcomas, where we see response rates of 50, 60, or even 70%, very, very active treatment, but only in this very specific, very small subgroup. Hormonal therapy is the treatment of choice in endometrial stromal sarcoma of the uterus. The already mentioned treatment with gemcitabine and docetaxel is especially well working in uterine leiomyosarcomas. Trabectedin will be discussed in a little more detail soon, is most active in the L sarcomas, leiomyosarcoma and liposarcoma, and also in the translocation-related sarcomas. Topo-1 inhibitors like topotecan or irinotecan show activity in pediatric rhabdomyosarcoma and in the Ewing tumors, but are completely inactive in the more common adult types of sarcomas. Sorafenib works also in angiosarcoma, and the insulin growth factor receptor monoclonal antibodies have shown activity, again only in Ewing tumors, desmoplastic small round cell tumors, and to some extent in solitary fibrous tumors. This list could be extended some longer, and I will give a couple of more examples to show what development is going on here in dividing the treatment for more specific treatment in the subgroups. Trabectedin doxorubicin as a first-line combination has given encouraging results for treating uterine leiomyosarcomas. There is a study from France publishing nearly 60% overall response rate and a very nice progression arrest rate with a median progression-free survival of 8 months, and this compares quite nicely to some older publications on doxorubicin ifosfamide and also gemcitabine docetaxel in uterine leiomyosarcomas with lower response rates and especially much lower progression-free survival. So trabectedin doxorubicin could become an interesting option for first-line therapy in uterine leiomyosarcoma. However, we would definitely need a randomized phase 3 trial to prove that this is indeed the case. Sorafenib again was studied in patients with soft tissue sarcoma in a large trial. The overall result was completely negative. However, 5 out of the 37 patients with angiosarcoma who were in part of this big study did show a response, and indeed the partial response rate was actually 14%. The only other subtype that has shown some benefit is leiomyosarcoma, where in another study a few patients out of the 30 with leiomyosarcoma showed some sort of response to sorafenib. Again, subtype specific activity. Solitary fibrous tumor, formerly also hemangiopericystoma, is a very rare disease, and it has been published many years ago that VEGF receptor 1 is found in nearly 100% of these tumors. So angiogenesis seems to play a major role, and this led to studying several targeted agents showing benefit of angiogenic therapy using either sorafenib or sunitinib in malignant hemangiopericystoma / solitary fibrous tumor. And there is one study from the MD Anderson using temozolomide and bevacizumab, also resulting in interesting response rates in this very rare tumor. Alveolar soft part sarcoma is a very interesting, extremely rare subtype of soft tissue sarcoma. It accounts for approximately 1% of soft tissue sarcoma, so it's the 1% out of the 1% within the adult cancers. Very rare. We expect to see about 30 patients in all Germany per year, so exceedingly rare and very unlikely that you will ever see some of these patients. The background is a translocation shown here that results in an ASPL-TFE3 fusion gene, and this finally leads to the activation of MET, showing in this rather complex scheme. So obviously, activation of MET seems to be the driving force behind alveolar soft part sarcoma, and if this would be the case, then we could expect some activity using drugs that are active in inhibition of MET. And this indeed is the case. There was one study using tivantinib, which is a selective MET inhibitor, in a phase 2 study targeting several MYT-associated tumors, microphthalmia transcription factor-associated tumors that have an overregulation of MET. And the results seen here are very interesting. There was a stable disease rate of nearly 80%, so the vast majority of patients benefited from MET inhibition, which is well explained by the mechanistic background of the disease. Just adding this, alveolar soft part sarcoma is highly resistant to all types of standard chemotherapy. The response rates are nearly 0%, with the sole exception of trabectedin, which seems to work quite nicely in alveolar soft parts, and this will be explained a little later why this may be the case. Sunitinib also has some activity in inhibiting MET, and this may well explain why it's also been shown to be effective in alveolar soft part sarcoma, with an interesting 88% progression-free survival at 6 months, and also a favorable proportion of patients responding to this treatment. Inflammatory myofibroblastic tumors, again an extremely rare subtype of soft tissue sarcoma, show in approximately 50% of cases a rearrangement of ALK. As you know, crizotinib is a selective inhibitor of ALK, and it was shown that crizotinib may work well in patients with inflammatory myofibroblastic tumors if they have the rearrangement. If the rearrangement is not present, and that's the other part of the group, 50% have yes, 50% have no, and crizotinib only works in those with ALK translocation. Again, proof of concept that this works. This led to a very interesting trial that shows definitely new clinical trial philosophy, basing a clinical trial on the molecular mechanism of disease and not on the histiotype. The CREATE study is studying the ALK inhibitor crizotinib in a range of different tumors, including anaplastic large cell lymphoma, inflammatory myofibroblastic tumors, papillary renal cell carcinoma, alveolar soft part sarcoma, clear cell sarcoma, and rhabdomyosarcoma. So this is one of the first studies not looking for a specific histiotype, but looking for an underlying specific molecular rearrangement. The study is going on across Europe. mTOR inhibition was shown to be active in PEComa, again an extremely rare subtype of soft tissue sarcomas. PEComa stands for perivascular epithelioid cell tumor. This belongs to the tuberosis sclerosis complex, and TSC1 and TSC2, tuberous sclerosis complex, mutations. So in either of these two complexes, if there is a mutation, this leads to the activation of the mTOR pathway. So we believe that PEComas are driven by mTOR pathway activation. And again, if this is indeed the case, mTOR inhibition should work. And this seems to be the case. We have a few case reports showing responses to either sirolimus or tensirolimus, both being mTOR inhibitors in this rare type of disease. Dermatofibrosarcoma protuberans is a very rare soft tissue sarcoma occurring mainly in the skin. This is driven by autocrine and paracrine activation of platelet-derived growth factor B and also the receptor. So this is stimulating, the disease is stimulating themselves. So stopping this by PDGF receptor B inhibition, which is achieved by using imatinib, has shown to be very active, and the activity of imatinib for this type of disease is again nearly 3/4 of the patients with good partial remissions or stable disease, and the median progression-free survival, 1.7 years, is also a quite rare condition to have such a long-term disease stabilization. Obviously, giant cell tumor of bone is not a soft tissue sarcoma, it's not even a real sarcoma. Nevertheless, I would like to spend 1 minute on this very rare and interesting tumor. Giant cell tumor of bone are driven by rank ligand activation, and the rank ligand stimulates the rank positive tumor giant cells, therefore leading again to a circulus with the tumor producing rankles stimulating the giant cells, and this is causing the disease. Denosumab is a fully human monoclonal antibody against rank ligand. So if we take off the rank ligand, then the disease will stop. And this is indeed the case. I'm only showing one of our first cases in this global study. This is a giant cell tumor of bone in a young 18-year-old lady. Huge tumor destroying the sacrum. This patient has failed a lot of different treatments, many surgeries, radiation, a couple of medical treatments, and after a few subcutaneous injections of denosumab, the tumor nearly went away. This is approximately 2 months treatment, very short-term therapy, showing the extreme high activity of denosumab in this type of disease with a benefit rate of more than 90%. Another interesting study was conducted targeting the Hedgehog signaling pathway. Hedgehog signaling pathway plays a very critical role in development in all animals and men. It's inactive in most adult cells, but it regulates a couple of basic proliferation issues, including also bone. The Hedgehog pathway is shown here. We have one molecule here called patched. Patched is inhibiting smoothened, and if patched is hit by the ligand, which is the Hedgehog, then the inhibition of smoothened is stopped. Smoothened moves to the cell surface and activates then gli, which then activates a couple of activities here in the nucleus. The Hedgehog pathway seems to be important in chondrosarcoma. Chondrosarcoma express very high levels of Hedgehog pathway factors, here shown nuclear gli1 in the majority of cases. So the idea was to inhibit the Hedgehog pathway in chondrosarcomas using a smoothened inhibitor called IPI 926. But this, unfortunately, in a large 100 patients, including phase 2 randomized double-blind study of IPI 926 compared to placebo in metastatic or locally advanced chondrosarcoma, did not prove feasible. That's the waterfall plot, and unfortunately only a minority of patients shown benefit to this Hedgehog pathway inhibitor, whereas it was inactive in the majority of patients. So the development of this drug, at least in chondrosarcoma, was stopped. Finally, moving on to a little bit more insights into trabectedin. It was established that trabectedin is not only working as a classical chemotherapeutic agent, but has a couple of more interesting mechanisms of action that may well explain the more subgroup-specific activity that was already mentioned. One of the major issues, nevertheless, is the DNA damaging by the drug, causing double-strand DNA breaks and therefore killing the tumor cells. In a small study, it was shown that the clinical response to trabectedin is influenced by the BRCA profile, and that we can identify a subgroup of patients with a specific profile that are more likely to respond to trabectedin. So patients with a high XPG and a low BRCA1 expression have a much better benefit from therapy than those who do not have this profile. Trabectedin also has a multi-target mechanism of action. It interacts with transcription factors, displacing the transcription factors from the DNA target, and this may be or is believed to be the explanation why trabectedin is especially working well in translocation-related sarcomas. Many soft tissue sarcomas carry gene translocations that are part of the pathogenesis, and this could explain why trabectedin works so well in some of these tumors. Myxoid liposarcoma is one subtype within the group of liposarcomas, and this disease is the one with the highest response probability to trabectedin therapy. And for this subgroup, actually, trabectedin is by far the most active drug compared to doxorubicin or any other drug. The overall response rate is approximately 50%, and the tumor control rate 90%. Median progression-free survival 14 months. The overall PFS rate for soft tissue sarcomas with doxorubicin-based chemotherapy is normally in the range of 6 to 8 or 9 months. So this is an extremely sensitive disease to trabectedin therapy. This study shows a subgroup analysis from the trabectedin studies looking for activity in patients with soft tissue sarcomas that are translocation related. And as you can see, those with translocations do better with trabectedin compared to other subtypes that do not carry translocations. This led to a randomized phase 3 study comparing trabectedin to doxorubicin-based standard chemotherapy in first-line treatment of patients with translocation-related sarcomas. Some of them are shown here: clear cell sarcoma, extraskeletal myxoid chondro, myxoid lipo, alveolar rhabdo, the desmoplastic small round cells, synovial sarcoma, alveolar soft part sarcoma discussed earlier on, and also endometrial stroma sarcoma after failure of hormonal therapy. Stratification was for myxoid liposarcomas versus others, and this is shown the result. The activity seems to be comparable between trabectedin and doxorubicin-based standard chemotherapy with respect to PFS and also with respect to overall survival. So at least for this subgroup, trabectedin might become a possible standard treatment also in first line. Finally, it was also shown that trabectedin does target the tumor microenvironment. Trabectedin kills monocytes and tumor-associated macrophages, which has been identified another interesting mechanism of action. Shown here, lymphocytes and tumorocytes are not targeted by trabectedin. However, the monocytes are killed very nicely, and also the tumor-associated macrophages. Some more classical chemotherapy agents like the taxanes and cisplatinum are not really working on the tumor-associated macrophages. Trabectedin also selectively suppresses some of the inflammatory cytokines, shown here, IL-6, VEGF, and are very nicely targeted. So this may also contribute to the mechanism of action of trabectedin in soft tissue sarcoma. Also here shown the reduction of blood levels in patients treated with trabectedin, looking for TAMs and blood vessels. So finally, in conclusion on trabectedin, trabectedin has multiple mechanisms of actions that work probably differently in different subtypes. For many patients, long-term disease stabilization is a major goal of treatment, and trabectedin offers a long-term tumor control, low response rate, but nice tumor control without cumulative toxicity. And more recent findings are the activity in translocation-related sarcomas in first line with a comparable activity to standard chemotherapy, and an interesting activity in combination with doxorubicin in the subgroup of uterine and not shown also other leiomyosarcomas. So in final conclusion, the identification and specific therapy of different subtypes of soft tissue sarcoma clearly leads the way. We should stop studying soft tissue sarcoma as a whole. Doesn't make sense to put up large trials looking on different subtypes, but we should try to identify subtypes based on their molecular pathology and pathogenesis, and should try to target these underlying causes of disease and identify the best possible treatment for each of these subtypes, instead of pulling them all together and fail to show activity of some of the treatments. Thank you very much.